Hello, welcome to my introduction to rheumatology talks. I've been a rheumatologist in practice for over 30 years, and during that time I've had the opportunity to give lectures to sophomore medical students in their Introduction to Medicine course on rheumatology. That's the basis for the lectures that I'm going to give. I've tried to avoid using jargon as much as possible when I made these, but occasionally I may use a word that I don't explain well. If I do, just feel free to look it up. The word could be typed into Google and you can generally find the meaning of it. The lectures will be posted in the order in which I made them, although many times they'll stand by themselves, so one doesn't necessarily need to watch all of them, and certainly you can pick and choose which talks might be of interest to you. I hope this is helpful to you and informative, and I hope that you learn something. Thank you for listening to my talks.
Hello, welcome all you budding rheumatologists. Today we're going to talk about the treatment of rheumatoid arthritis. The last talk I talked a bit about rheumatoid arthritis, how it affects the body, what it is, how we diagnose it. Today I want to spend some time talking about the treatment. I'm going to spend a lot more time talking about the treatment of this than other conditions, which we'll delve into for two reasons. Number one, I think there's probably some interest in how we approach therapy, and number two, because I have a lot to say about it. First, I'm going to discuss the medicines that we use to treat it. Then I'll be discussing history of how we came to our present therapeutic protocols, and lastly I'll be talking a bit about the sort of the present protocol that's recommended, at least by the American College of Rheumatology. So first I'm going to talk about the non-steroidal anti-inflammatory drugs. These have been used to treat rheumatoid arthritis for many, many years. Especially back in the day, high doses of aspirin were used, and aspirin is a type of non-steroidal anti-inflammatory drug. However, of late their use has been more supportive early in the course of the disease, and they're not used so much for the ultimate therapy. Basically, the non-steroidal anti-inflammatory drugs work by affecting cyclooxygenase function. That's what COX stands for. Cyclooxygenase is important in a lot of the functions involved with inflammation and pain, especially at the periphery, by periphery out further in the body at the joints, because pain is mediated all the way up to the central nervous system. They also are involved in a lot of what we call constitutive functions, such as maintaining the mucosal lining of the stomach, platelet function, and kidney function. The cyclooxygenase inhibitors or non-steroidal anti-inflammatory drugs, as I mentioned, have been around for many years, but they were found to have a lot of side effects. In particular, they cause stomach ulcers, affect the kidneys, etc. So back in the late 80s, early 90s, it was found that there was actually at least a couple of forms of cyclooxygenase. Cyclooxygenase 1 or COX-1 was found to be important for the constitutive features such as platelet function and mucosal lining, whereas cyclooxygenase 2 was felt to be important for mediation of pain and inflammation. So back in the 90s they came up with some non-steroidal anti-inflammatory drugs that just affected the COX-2. These were felt to be, at least initially felt, that they would be safer because there would be less risk of stomach ulcers and stuff, and they were found to be helpful in the treatment of the arthritis, both inflammatory and non-inflammatory. However, because they didn't tend to bother the stomach as much, the doses were pushed very high, and it was found that in doing that there's an increased cardiovascular risk with the non-steroidal anti-inflammatory drugs. So the use of the COX-2 selectives soon waned, and there's presently only one on the market called celecoxib, or also known as Celebrex. Currently, as I said, they're used more to just sort of help with the early inflammation and pain, and they're really not the treatment. The next medicine that we'll discuss are the corticosteroids. These are things like prednisone, and a lot of times corticosteroids are also injected into the joint. Their benefit was found and their use was initiated back in the late 1940s, and they almost have a magical effect on the inflammatory arthritis, rheumatoid arthritis, at least early on. Their function is that they inhibit the synthesis of a lot of known cytokines. These are the cellular messengers we talked about last time. They affect the trafficking of the leukocyte or the white blood cells, so they're less inclined to march into the joint and cause inflammation. They can affect cyclooxygenase 2 function. They decrease the number of circulating T lymphocytes, and as you recall, this is one of the main mediators of rheumatoid arthritis, and this is far from an exhaustive list. So as you could see, they do have a lot of potential benefits. However, the problem is their benefits are very closely linked to their side effects, and there are many. They can cause thinning of the skin. A lot of times people will get sort of stretch marks, can have cataracts, they can have glaucoma. They can promote or accelerate atherosclerosis because they can affect lipids. They tend not to cause peptic ulcer disease by themselves, but when used with non-steroidal anti-inflammatory drugs, they actually can double the risk of peptic ulcer disease with the non-steroidals. They can raise blood pressure, they can cause osteoporosis, they can cause death of the bone, we call avascular necrosis. They can cause growth retardation in children. They can cause a weakness called a steroid myopathy. They can affect the central nervous system, and sometimes people will get a euphoria or almost a mania, or can sometimes become frankly psychotic. They can affect glucose metabolism, cause diabetes. They can cause weight gain, and this is a very common side effect, and people notice it a lot, and they increase the risk of infection. So again, these medicines have almost a magical effect, but if we use them in very low dose, and we tend to not use very long if we can get away with it. Next, we'll discuss the disease-modifying anti-rheumatic drugs, which we abbreviate DMARDs. These are the medicines that actually change the course of the disease, and these are the medicines we'll talk most about as we move forward when we start talking about treatment strategies. The first I'm going to talk about is the antimalarials, specifically hydroxychloroquine. The name brand for this is Plaquenil. This medicine a lot of people have probably heard about because it had some interest early during the COVID-19 pandemic. Research following that really didn't show a lot of benefit in the treatment of COVID, but the medicines do have a lot of benefit with respect to treating rheumatoid arthritis and systemic lupus and stuff like that. These have been around for many years, and we're still trying to understand how they beneficially affect these diseases, but it does look like they affect the acid microenvironment in the cellular compartments, in particular the lysozymes. The lysozymes are involved in the digestion of proteins and stuff that the cells such as the macrophage might take in. And if you recall, the macrophage is important in taking in some of the cellular debris, sort of eating it up and presenting it to the T cell to sort of generate the immune response. They do have multiple side effects. Most of them don't occur very often. However, the one that we watch for most carefully and closely is they can affect the retina of the eye. I like the use of the antimalarials because they're basically generally don't have a lot of side effects and patients tolerate them well. Next, I would like to talk about sulfasalazine or azolvadine. This has several methods of action. Number one, it inhibits prostanoids. This includes the prostaglandins and several other molecules that can affect inflammation. It also decreases the number of circulating lymphocytes. As you recall, the T lymphocytes key in the modulation or the action of the immune system in rheumatoid arthritis. They do have problems, however. They can suppress the bone marrow, or what we call myelosuppression. Patients can have photosensitivity, which means they tend to be more reactive to sunlight and can have rashes. It is a sulfa type of molecule, so a lot of times there's allergic reactions like patients have with sulfa. The next is gold therapy. Again, this is a medicine that's been around for many years, and actually its use is waning rapidly. However, back 30 plus years ago, when I was in training, this medicine was actually the gold standard in the therapy of rheumatoid arthritis. The actions of it are, there's a lot of actions that they've studied. The importance and benefit is not really known. They can affect the bone marrow, so it needs to be monitored for the blood counts need to be monitored. They can cause oral ulcers and rashes, and they can affect the kidney and cause protein in the urine. Many years ago, when we were using gold a lot, it was available as an intramuscular injection, and that was how it was used most frequently. That is no longer available, and now primarily it's just used as a pill. And again, it's not used a lot. Okay, so this is just again our schematic of how we think the immune system is sort of revving itself up during rheumatoid arthritis, with the presentation of the macrophage presenting the cellular debris to the T cell, and then that sort of mediates the immune response. The next medicine we're going to talk about are the purine nucleotides. The purines and the pyrimidines are sort of the molecules that make up DNA, and by blocking their function, it decreases the ability of cells to divide. In patients with autoimmune disease and cancers also, by stopping cell division, we stop function. The first one I want to talk about is methotrexate. This is actually one of the gold standards in the treatment of rheumatoid arthritis, and it's found its way into our regimen back in the late 70s and the 1980s. There are studies done per Dr. Weinblatt that did show benefit, and it quickly became the cornerstone therapy. The problem with methotrexate is it's generally well tolerated, but it can cause oral ulcers and affect the lungs, cause what we call a pneumonitis, can affect the liver and cause bone marrow suppression. Azathioprine is another purine nucleotide blocker. It's also known as Imuran. This medicine was used initially for cancer therapy and then for immune suppressions with transplantation. We do use it a lot in the treatment of rheumatoid and a lot of the other autoimmune diseases we treat. The problems with azathioprine, again, it can suppress the bone marrow. Sometimes there can be liver involvement, although not as great as we see with methotrexate. We tend not to see the pulmonary involvement, and unfortunately on the package insert they do list the increased risk of cancer. This, however, is true of a lot of our medicine. It's probably because we're affecting immune surveillance as we turn down the immune system trying to treat the disease. The immune system is important trying to screen for cancers in the body. Now, the other type or class of molecules that makes up DNA are the pyrimidines, and there's a medicine called leflunomide, which is also known as Arava, which was actually designed to treat rheumatoid arthritis, and it is shown to be very beneficial. It does have some side effects in that it can also affect the liver and the bone marrow, and one side effect sort of unique to it is that there can be some diarrhea associated with it and weight loss. There's actually some interesting data to suggest the combination of methotrexate with leflunomide has more benefits than methotrexate alone, and probably doesn't have any more side effects. The next several medicines that I'm going to talk about are of the class that we call biologics. Basically, these are genetically engineered molecules that attack certain things, and in rheumatology we're interested in turning down the immune system, so most frequently these are targeted against the cytokines, the cellular messengers. And and in trying to block the action of those cytokines, we turn down the immune system and thus decrease the amount of disease. The first one I'm going to talk about, and actually the first one, or at least one of the early ones that was available, is the tumor necrosis factor alpha, or TNF alpha antagonist. Basically, there's several of these, and I've listed them here. Etanercept is interesting in that it is a fusion protein of the TNF receptor and the constant portion of an immunoglobulin molecule. And I'm not going to talk about what that means a whole lot, because there's a lot of things like this in the next few medicines we'll talk about. So if you want to know more about them, I'd encourage you to research that on your own on the internet. Infliximab is another one, also known as Remicade. This is a fusion protein between the mouse variable region of an immunoglobulin molecule and the constant portion of a human immunoglobulin molecule. Adalimumab, Humira is another name for that, is a fully human immunoglobulin IgG to the TNF alpha. Golimumab, or Simponi, is another fully human antibody to TNF. And certolizumab, or Cimzia, is interesting in that it's a pegylated molecule. And basically, pegylation, what that is a non-toxic, non-immunologic polymer. Plastics, for example, or polymers, is attached to the molecule, and this changes its immunicity so that we don't get an immune response to the molecule, and it changes how long, or its half-life in the body. Having said that, I don't find any particular advantage of one of these over the others. I tend to use etanercept or Enbrel most often. I have the most experience with that. That's been around the longest. With respect to side effects of these medicines, there's not a lot of minor side effects associated, perhaps an occasional injection site reaction. All these medicines can increase the risk of infection, as one can imagine, because we are turning down the immune system. They are contraindicated in active infection. We always check to see if there's latent TB before initiating it, and they're contraindicated in tuberculosis. Statistically, as we discussed with azathioprine, there is a slight increased risk of cancer associated. Again, we are turning down the immune system, which is important for immune surveillance. They are not to be used in people that have demyelinating disease, such as multiple sclerosis, nor in people that have congestive heart failure. And probably one other side effect is occasionally they can cause an autoimmune disease like lupus. I've not really seen a lot of that, maybe just one or two cases, but it can occur. They can also at times elevate liver function tests and lower the white count. Now, having said all this, I find these very useful medicines, very effective, and really the side effects don't happen that often. Now, IL-1, as we see here, interleukin-1, seems like it could be a good target for treatment of rheumatoid arthritis, and indeed, again, back when the TNF alpha treatments such as etanercept and infliximab came out, a medicine called anakinra or Kineret came out, which is a recombinant human antibody, and block the effect of IL-1. However, it's really not been shown to be that helpful in rheumatoid arthritis. I really don't use it much for that. There was a lot of injection site pain, and it was a frequent shot. It was given daily. However, it has been shown to be useful in autoinflammatory disease, and it's particularly useful in the treatment of Still's disease, which in children is called systemic onset juvenile idiopathic arthritis, but there's an adult variant of that, and these patients can get very sick with high fevers, etc. Canakinumab or Ilaris is also indicated for Still's disease. It's not really indicated for rheumatoid. And there's another IL-1 blocker called rilonacept or Arcalyst, it's useful for other autoinflammatory diseases, and again, not really indicated for rheumatoid arthritis. The next one is co-stimulation modulators. It's not shown in this picture, but as you recall, when the macrophage presents the antigen to the T cell, there's a lot of co-stimulation, other cytokines produced, but there's also attachment to the CD4 cell with the macrophage. And so the medicine abatacept blocks that attachment, and in doing that we find we significantly can help rheumatoid disease. Indeed, this medicine, abatacept, another name for that is Orencia, has been shown to be very helpful in people that are failing the TNF blockers. There's at least a 50% capture rate of patients that are given Orencia when they failed TNF blockers. Rituximab, which is the next medicine we'll talk about, actually removes the B lymphocyte. CD20 is on the B lymphocyte, and doing that it removes the B lymphocyte. Its other indication is in lymphoma. Obviously, if we remove B cell lymphomas or B cells from a B cell lymphoma, we get control of that. But it's also been shown to be very useful in the treatment of rheumatoid disease. There are some risks associated with it. There's increased risk of infusion reactions. A lot of times patients can have rash, mouth lesions, inflammation of the lining of the mouth. They can have reactivation of hepatitis B. Perhaps one of the more worrisome potential risk is infection of the brain, which we call progressive multifocal leukoencephalopathy, or PML. This doesn't occur very often, but certainly it was something one would want to avoid. Other infections can occur because of the removal of the B lymphocyte. There's an increased risk of cardiovascular reactions, renal toxicity, and bowel obstruction. Now, having said this, I don't really use rituximab very much in the treatment of rheumatoid disease, but there are other diseases in rheumatology that's been shown to be very helpful. In particular, granulomatosis with polyangiitis, or which is a type of vasculitis previously referred to as Wagner's. It's been shown to be very helpful in that. Interleukin-6 blockade can be accomplished with one of a couple of medicines. One is called tocilizumab or Actimra. The other is called seralumab or Kevzara. I find these medicines to be very helpful, and although again I usually use the TNF blockers or the co-stimulatory modulators first. Interestingly, these medicines have found their way into the regimen to treat COVID-19, probably because they decrease some of the immune response to it and thus decrease a lot of the inflammation that can occur in the lung. A new class of medicines are what we call Janus kinase signal transducer activator transcription inhibitors, or JAK-STAT inhibitors, and there's several I listed here: tafasitamab, which is Xeljanz; upadacitinib, which is Rinvoq; and baricitinib, which is Olumiant. These don't work on the receptors themselves, but they work on what happens in the cell after the receptor is stimulated. In order for the stimulation of the cytokine to have benefit, we have to have an intracellular response that affects the function of the cell, and these block that. So they do have a different mechanism of action. Now, not all cytokines use this pathway in order to affect their function. IL-6 or interleukin-6, which we just discussed, can, but TNF actually does not. Tumor necrosis factor does not. one of the unique properties of these medicines is that they are smaller molecules, so they can be taken as a pill. And this is different than the last molecules that we saw, which are all have to be taken either as a subcutaneous shot or an intravenous infusion. These can be taken as a pill. There are several potential side effects associated with these. There's an increased risk of upper respiratory tract infections, urinary tract infections, nausea, vomiting, and diarrhea. But of greater concern, indeed, these have black box warnings on their package insert. There's an increased risk of cardiovascular events and mortality. There's increased risk of infections such as zoster, tuberculosis, and other opportunistic infections. They can lower the white blood count. There is an increased risk of intestinal perforation. They can elevate liver function tests. They can cause blood clots, and as with the other ones we discussed, there's a slight increased risk of cancer. Thus, I think their role or where they're falling is still to be debated. The insurance companies prefer these. I think they're getting good deals with the insurance companies, so a lot of times they're in our list of medicines that we use early because we're forced to, but I think their ultimate role is still to be determined. So where might we go with therapy in the future for these diseases? And these are just some thoughts of potential future targets. I'm not aware of any studies ongoing with these, although there may be. Number one, the macrophage is, you recall, is very important in the presentation, the antigen, and sort of initiation of the response, and that would be a potential target. Interleukin 4 and interleukin 2 actually down-regulate this process, and maybe IL-1 and IL-10 analogs would be a good site. We talked about the Pannus and how that's almost a tumor-like, and that there's a big growth of blood cells in order to encourage and grow the Pannus. Blood cells blood vessels are sort of stimulated by what we call vascular endothelial growth factor, and there actually are vascular endothelial growth factor inhibitors that are used in the treatment of cancer. Perhaps these would have benefit in the treatment of rheumatoid arthritis. And then lastly, adhesion molecules, the adhesion of the macrophage to the lymphocyte. Perhaps if those were blocked, we could affect the immune response and turn down the activity of rheumatoid arthritis. So I've now gone through the medicines that we have to treat it. I think at this point it is important to talk about how we use those medicines. And I think what I'm going to do first is let me go through some of the history of how we treated that, and then after I do that, I'm going to give the most recent recommendations from the American College of Rheumatology. Okay, so this was the classic treatment pyramid, and this was what we used back in the day when I was a lad to treat rheumatoid disease. And basically just started with rest, not necessarily even medicines, although if the medicines we added were usually the non-steroidals or very high dose of salicylates, aspirin, and we would push the aspirin to doses of toxicity. A lot of times we'd titrate those up to the point where the patients had ringing in their ears. If we weren't getting anywhere, at that point we would consider disease-modifying drugs. As I mentioned, gold was the gold standard. We also used something called D-penicillamine, and of course hydroxychloroquine, which we still use. If that wasn't useful, then we might try something like methotrexate or azathioprine. And then experimental methods, and experimental methods were basically other chemotherapies. Glucocorticoids were used throughout treatment, either systemically or intra-articularly. We've exploded that. That's not the way we do it anymore. Now, methotrexate has been the standard of care for many years, probably dating back, as we discussed, to the 1980s. However, in the 1990s, it was felt that better treatment was needed. And this was just a landmark study by Odell and group. And basically what they showed was the combination of three drugs, methotrexate plus sulfasalazine plus hydroxychloroquine, was much more beneficial than the drug singly. And these are just how well they responded from time zero moving forward. And you can see as they move forward, fewer and fewer people were getting a good response to just single drug therapy. So this is one of the studies, and I say one of the studies, there's certainly other studies that showed the benefit of combination therapy, but I think this is one of the important studies that showed the benefits of combination therapy. Now in this study, they initiated treatment early in patients that had disease before 4 months and compared to patients that had treatment after 4 months of therapy. And what they found was if you were just using a single drug, there was a much better capturing of the disease at 4 months than if you waited for 4 months. But probably more important was they showed that if it was early disease, combination therapy was about the same as single drug therapy, but if it was later disease, more than 4 months, it made more sense to use combination therapy because the response was 42% versus 11%. So this again showed that the response was better. And that the sharp scores is just the measure of the amount of erosions of the bone around the joint. The sharp scores were better. So again, emphasis on perhaps the benefit of combination therapy, but also more emphasis on the fact that treatment has to be initiated early and aggressively. I'm sort of embarrassed to show this slide. It's very complicated and a tabulation of multiple studies and trials, but I just want to point out one thing on this. Number one is an explanation. The ACR 20%, 50%, and 70% were definitions given to sort of describe how well one was responding. And they looked at several factors and then they determined, well, if they respond, there is a 20% response to several of the factors as a 20% responder, likewise 50% and 70%. So obviously one would rather be a 70% responder than a 20% responder, but the usefulness of this in studies was at least so they could measure and tell if they were getting any response at all. These are studies comparing methotrexate, etanercept, and the combination, and basically I want to look down here at the 12-month data. And these are patients, how well they responded after 12 months. And what's interesting is if we look at the ACR 50% at this, if we use methotrexate alone, there was a 43% response. If we use etanercept or Imbro alone, there was a 48% response. However, if we use the combination of the TNF, etanercept, or Imbro with methotrexate, we were able to maintain a 69% response at 1 year. Thus, I think this is good data to suggest that there is benefit in using a TNF blocker with methotrexate. Now, again, this is another timing study, and basically what they did was they used methotrexate or the TNF blocker infliximab or the combination, and what they looked at was how many erosive sites were determined in the number of weeks, and so they went out to a month. And what they showed was by initiating combination therapy very early, infliximab plus methotrexate, they were able to significantly decrease the number of erosive sites. This was methotrexate alone, and then this is a combination of the infliximab with methotrexate. You can see that there's much less erosive sites. Now this is just looking at data from that study we discussed on the last slide a little differently. And what they looked at is the disease activity score, which we've talked about, the disease activity score 28, and then they followed and saw what that did as they moved forward. And again, they were comparing methotrexate alone to the combination of methotrexate with infliximab. And what they showed is even as you stretched out past a year, that there was a much better response of the patients that were on the combination therapy rather than methotrexate alone. Again, indication for the use of both methotrexate plus a TNF blocker. So this was a study that I thought was very interesting. This was published in 2004, however, I think was presented at the American College of Rheumatology before that, because I remember this study. And basically this was done in Britain, where of course they have the National Health Service, and what they used was a very aggressive approach to therapy. They saw the patients monthly. They determined what are called disease activity scores monthly. The patients had less than 5 years of disease, and when they saw the patients, they aggressively moved therapy up, starting with just sulfasalazine, but if they did not respond, quickly moving to a combination, triple drug combination of sulfasalazine, methotrexate, and hydroxychloroquine. The only medicine they used beyond that was cyclosporin, which is another immune suppressive drug, and I didn't list it because I don't use it in my practice, and it's not really in any of our protocols now. They also aggressively injected the joints. If there was a swollen joint, they would inject it with corticosteroid, and their goal is to try to get a disease activity score in remission or low disease activity. With this study, they showed that they could get the ACR 50 response of 84% versus 40%, which was standard therapy, which we had talked about, sort of gradually building with rest and gradually building up through methotrexate. They did have a decrease in erosions, and interesting, and this was important for the British Health Service in particular, the overall cost of therapy was less. Now this is just to discuss the disease activity score, which I've made reference to a couple of times. And there are actually several scoring systems. Basically, we use these scoring systems in order to give us some sort of objective measure of disease activity. Some of them, like the health assessment questionnaire or the rapid 3, which I sort of to me looks a lot like the health assessment questionnaire, just ask patients about how they're feeling, how they're functioning, stuff like this. I like the disease activity score 28 because it's actually, there's some objective measures like the SED rate and the swollen joint count, which is performed by the rheumatologist. So basically the rheumatologist does an exam. He documents which joints, and these are the joints that are of interest. There are 28 of them. He documents how many of these are tender to touch, how many are swollen, and that's by squeezing the joints. That's what rheumatologists do. The patient does a visual analog scale, and basically this is a scale of 0 to 100 millimeters, and the patient marks how active the disease is. So if there's no activity of the disease, 0. If it's very active, 100%. And then the SED rate, the Westergen sedimentation rate, is measured. And then there's calculators that can be used. These are online, or you can actually get a spreadsheet to put in your computer that calculate the calculator. And then we determine the disease activity score, and then we can rank them from less than 2.6 to remission all the way up to greater than 5.1 is high disease activity. And so these can be used then to go through and determine where you are in the course of the disease. And as per the Tigora study, this data can be used to go back and affect the treatments that you use. This led to the concept of what we call treat to target, whereas rather than just initiating treatment, seeing how the patients do, we actually set a target goal, again, either remission or low disease activity, and escalate our treatments to get to that goal. And that's sort of spreading through other treatment of other diseases in rheumatology right now also. Lastly, I'd like to give a brief discussion about the current American College of Rheumatology treatment guidelines. Basically what treatment guidelines are is a set of, and I use the word suggestions, nothing's written in stone, produced by the American College of Rheumatology every few years for certain things, such as approach to therapy, sometimes approach to monitoring of medicines, or approach to diagnosis of certain conditions. With rheumatoid arthritis, these have been done quite frequently, and I think in reviewing for this discussion, I looked at the 2008, 2012, 2015, and 2021 guidelines. These are available at www.rheumatology.org. And I think that you can access those even if you are not a member of the American College of Rheumatology. I obviously can get through via membership, but I think you can get them even if you're not a member. Now, the most current guidelines, and I state dating back several sets back to I think even 2008, the goal has been to treat to target. So again, the idea is to measure some level of disease activity, such as the disease activity score, like we talked about things like RAPID-3, and there's several other of these. The current guidelines suggest that unless there's low disease activity, that methotrexate should be started early. Okay, now with low disease activity, hydroxychloroquine was suggested. It doesn't look like there's a difference in the current guidelines whether the patient's disease has been a very new diagnosis or if it's been somewhat established and they're just finally presenting for treatment. The older guidelines would suggest perhaps being more aggressive and maybe considering triple drug therapy if the patient has more established disease. The methotrexate is then rapidly maximized. Generally, it's pushed up to at least 15 milligrams per week early, and sometimes pushed as high as 25 milligrams per week. If the patient doesn't have a sufficient response at that point, in other words, getting down to low disease activity or remission, then a biologic is added. So at least the most current guidelines move to a biologic very quickly compared to previous guidelines. Now, if the patient does not respond to the biologic, and again, probably within a few months, although I would submit that the medicine abatacept or Orencia has a much longer onset of action. If they don't, but most typically we'll use a TNF blocker first anyway. If they don't respond to the TNF blocker first, then a biologic of a different class is suggested. So, for instance, if you're using a TNF blocker, it suggests you move to something other than a TNF blocker. Now, having said that, I've had a lot of grief from insurance companies because they don't seem to understand that, and if we've used one TNF blocker, they'll maybe ask us to use another TNF blocker before we move on. So either a biologic of a different class or possibly a Janus kinase inhibitor if that's not sufficient. And then so we do that. We have lots of tools right now. We can move from one to the other, but again, our goal is to treat to target. We want to get control of this disease. So that's the conclusion of my discussion about treatment of rheumatoid arthritis. Again, this rheumatoid arthritis can be a devastating disease. It can take away function. It can cause a lot of damage to the joints and the body. It can cause disability, and we've even talked about how it can shorten life. And so I think there's a lot of need to be very aggressive in the treatment of the disease, to recognize the disease early, to initiate treatment early, to treat to target, modify treatment until we get remission. And we think if we do that, we can actually change the outcome of the disease. I do think that this is a specialty disease, and what I mean by that is I think this medicine, the people that have this condition should be referred to rheumatologists in order to be managed and followed in order to achieve optimal outcomes. Again, thank you very much for listening to my discussion. The next discussion I will be presenting will be on systemic lupus erythematosus. As I mentioned, in the future, I do not intend to have such a long discussion about therapy, but I think for rheumatoid arthritis at least it's warranted. Thank you.
So that concludes this talk. I thank you very much, and there'll be further to follow.